We aimed to evaluate the rates of access-related injuries during minimally invasive ventral hernia repair. To date, there is no clear consensus as to the optimal method of entry to prevent these low-rate yet catastrophic complications. We performed a retrospective review of the prospectively collected AHS-QC database. There were 6,731 patients in our final analysis. 34% of these utilized the varus needle approach, 54% utilized optical trocar, and 12% utilized open cut-down access. Only 3 access-related injuries occurred, resulting in a rate of 0.4 injuries per 1,000 operations. All injuries involved the liver and occurred with either varus or optical trocar insertion. There was no difference in the rates of intraoperative complications between the approaches. No differences were seen in access-related injuries, intraoperative complications, SSIs, or SSOs between robotic and laparoscopic cases. However, the rates of SSOs were significantly different between open cut-down at 5%, varus needle at 6.83%, and optical trocar at 10.58%, with a p-value of less than 0.001. The rates of SSOs did decrease over a 5-year span in all 3 approaches, as seen in Figure 1a. The largest drop occurred in robotic approaches, as seen in Figure 1b. In the same time period, we saw an uptick in robotic ventral hernia repairs, as seen in Figure 2. Logistical regression showed that for every prior hernia repair, SSOs increased by a factor of 1.2 and SSIs increased by a factor of 1.5. Even more dramatic, the odds of having an SSI complication was 3.35 times higher in a patient with prior component separations than in a patient who does not. The odds of someone having an SSO complication was 1.6 times higher in a patient with optical trocar entry compared to varus entry. Ultimately, while we saw no access-related injuries occurring with open cut-down techniques through 804 ventral hernia repairs, all 3 techniques had extremely low rates of access-related injury. Despite having over 6,000 cases, we were not adequately powered to detect a statistical difference with 0.04% event rate. However, optical trocar entry for ventral hernia repair does appear inferior when considering SSO rates, especially in patients with prior ventral hernia repairs. The rapid rise in ventral hernia repairs along with the decrease in SSO rates may suggest a learning curve with these newer robotic techniques. Still, no statistically significant differences were seen between laparoscopic and robotic techniques. Moving forward, prospective studies may be needed to identify the true rates of complications as surgeons develop additional competency with novel ventral hernia repair techniques. Additionally, larger studies powered to detect these extremely low-rate access-related complications are needed to help develop consensus on the optimal technique for peritoneal access. I'd like to thank Dr. Palos, Anand Gupta, and Savannah Renshaw for their contributions to this project. And finally, I have no disclosures to note.